So this is my newborn assessment video. So when I come in the room, I'm going to perform hand hygiene. I'm going to check the baby's identifier with the MRN band and the date of birth when compare it to mom's band, and the two should match. So before I start, I'm going to make sure that the baby is placed in a warm environment. I want to make sure the baby is in a radiant warmer or something similar, and have the baby covered up and only expose parts when I need to examine them. I'm going to be using a soft voice and gentle movements. I don't want to startle the baby except when I'm testing for specific things. I'll also have warm hands, and when I use my stethoscope, make sure that is warm as well. So first, when we start with vital signs, we're going to check the temperature. We're going to take an axillary temperature, and it should be around 36.5 to 37.2 degrees Celsius. The pulse ox should be above 90% O2 saturation on room air. And we don't usually take the blood pressure, but if we do, we use the appropriate size cuff in the arm or the leg, and it's going to be about 50 to 70 millimeters diastolic and 30 to 40 millimeters mercury systolic. And then we're going to find the apical pulse, and it's going to be the point of maximum impact, and we're going to palpate and listen and feel for a full minute. And this should be around 110 to 160 beats per minute. And then the blood glucose in a newborn should be around 40 to 80. And so before we go into all the systems, we're just going to look at the posture of the baby. And the baby should have flexion at the elbows, hips, and knees. The movements should be coordinated but sporadic, and they should be symmetrical and pretty midline. And the baby should weigh about 2,500 to 4,000 grams. And like I said, we find that apical pulse for the rate, and then we're also going to compare these to the brachial pulses and the femoral pulses, which we palpate here. And those should be the same with the same rate and force. And we're going to listen to the heart sounds, and the heart sounds should be, it can have swishing sounds of a heart murmur is normal in a newborn. And we're also going to be listening to the breathing, and we should be seeing a symmetrical chest expansion, and the abdomen can't actually move more than the chest in a newborn. And we should be counting 30 to 60 breaths per minute, and we count beat for a full minute since the rate is irregular. We're going to be looking for signs and symptoms of respiratory distress. We don't want to see retractions or nasal flaring or a rapid rate. And then when we start, we're going to be starting in the upper lobes and move laterally onto the sides. And we're going to be listening for adventitious sounds, crackles, or rhonchi. And then the baby will have a strong cry with a moderate pitch. And then we're going to be looking at the skin of the baby, and it should be soft and smooth with deep cracks on the abdomen, and blood vessels should be faintly visible. Peeling is normal in the post-mature newborn, but not in the term newborn. And we will assess turgor by gently pinching a little bit of skin. It should snap back immediately. And acrocyanosis is not unusual in the first 24 hours. Central cyanosis is. We could also see some mottling, lanugo, vernix caseosus, milia, Mongolian spots. We could see erythema toxicum neonatorum. And then to check for jaundice, we're going to blanch the skin over a bony prominence. And then we're also going to assess the sclera. And some measurements for the newborn should be from top to bottom. We're going to measure from the top of the head to the sole of the foot. And the baby should be 48 to 52 centimeters. The head circumference will go around the largest part of the head and hit the eyebrow line, and that should be 32 to 37 centimeters. And the chest circumference will be at the nipple level and the lower edge of the scapula, and this should be 2 to 3 centimeters smaller than the head, so 30 to 35 centimeters. And then while we're here, we're going to just check the baby's head, and we're going to gently support the head and palpate the fontanelle and suture lines. And these suture lines may overlap, and we'll feel these ridges. The fontanelle should be soft, however, flat and firm, and we could feel a pulsation. The head should be normocephalic and symmetrical. The anterior fontanelle is diamond shaped, and the posterior fontanelle is triangle shaped. The hair texture should be fine and silky, and we could see the caput succedaneum or the cephalohematoma, and these could be related to birth trauma and present in the newborn. To assess like the facial symmetry, we're going to watch when the newborn is crying, because that is how we can best see the expressions and grimaces that they make. There should be no paralyses. It should be symmetric. And we could see some vascular birthmarks on the face, and if forceps were used during birth, we could see forceps marks on the face. So then while we're in the face, we're going to look at the eyes, and there could be some eyelid edema common in newborns. So you might need to wait until they're relaxed to open their eyelids and look at their eyes. And the iris will be deep blue, and the sclera is going to be a bluish white. It is common to have a small hemorrhage related to birth trauma, and we're going to take the ophthalmoscope and look in the eyes, and we're going to watch for restriction of pupil, intact lens with the red reflex. And then we're going to look at the ears, and the ears should be aligned that the top of the ear lines up with the outer canthus, so the pinna to the outer canthus. The pinna should be well curved, and we should feel like strong cartilage formation. We could see epicanthal folds around the eyes, and we could see strabismus, but this could go away, or we could see pseudostrabismus. The ears will be firm and like readily spring back into place if you move them around. The ears should be like symmetrical with each other, and hearing can be evaluated with a loud noise, and it will startle the newborn. So for the nose, it should be symmetrical with should be midline of the face. We're going to check the patency of the nares, and we're going to wait. We're going to make sure the baby's mouth is closed, so we could use a pacifier. And we're going to occlude one nostril at a time and make sure that the baby is still perfusing oxygen and breathing through each nostril. And then we'll repeat for the other side. The nose may appear flattened and small in the newborn. And then for the mouth, the lips and mucous membranes should be pink and moist. And when baby's crying, that's a good time to assess the oral cavity, because we can see the hard and soft palates. If not, we can use our fingers and move in there, palpate along the gum lines. The tongue should be freely moving. We should feel the well-defined hard palate. The uvula should be midline and moving symmetrically. The tongue will be freely moving. We could see a gag reflex when we're poking around in there. And we could see Epstein pearls on the hard palate. As far as the neck on the baby, we're going to see short. It's going to be pretty short, and it's going to be creased with lots of skin folds. So we're going to like try to separate the skin to feel for any masses or swollen lymph nodes. And then we can turn the head from side to side to assess for the full range of motion. And then we're going to examine the integrity of the clavicle. It should be straight. We shouldn't feel any ridges, because this would indicate a possible break from birth. And then the chest, we already talked about the chest circumference measurement. So the areola is full, and it would be about 5 to 10 millimeter tissue bud. And breast engorgement is normal in the newborn in both males and females. And so moving on to the abdomen, we're going to see a rounded abdomen. We're going to listen in all 4 quadrants for active bowel sounds. The umbilical cord should be 3 vessels, 2 arteries, and 1 vein. We should see no oozing or bleeding. It could be a white yellowish color. We're going to have light palpation and feel for abdominal tone and masses. And then we can deeply palpate for the liver and the tip of the spleen, but you can't necessarily feel this in every baby. So for males, the uncircumcised male, the foreskin will adhere to the glands, and the scrotum is going to be dark pink in Caucasians, and it's going to be dark brown in darker skinned babies. The scrotum will have rugae, and the testes should be palpated, and around 40 weeks they will be descended. In the female, the lower labia majora will be very swollen and cover the labia minora and the clitoris. And the urethra and vaginal orifices can be seen when we peel back the majora. And we might see a white or blood-tinged mucus discharge, and we could see some redness, some pseudomenses from withdrawal of mom's hormones. For genitourinary for both males and females, we're going to look for the urinary meatus and make sure that it's symmetrical and midline. And we're going to monitor I&O. We're going to check the position the urinary meatus. Urine should be yellow, clear, with mild odor. And then for those girls, we might see the brick dust blood from the pseudo-menstruation. And then to check the anal patency on the baby, we're going to stroke next to the anus and check for that anal reflex. We're also going to feel for lumps in the inguinal area. And then while we're here, we're going to assess the hips. So we're going to make sure that the knees are at equal height, and we're going to make sure that the hips are not dislocated. So we're going to hold the baby's legs, and we're going to make sure that the knees are at a 90-degree angle, and we're going to apply gentle downward pressure of the knees for adduction towards the midline. And this is the Barlow test. So it's going to be out, and we're going to go in, and this is testing if the hip is dislocatable. And we don't want to feel any like popping or crackling. And then the Ortolani test is used to confirm the Barlow test. And we're going to abduct and move the hips outward. And this will be the reduction of the dislocated hip, if there is a dislocated hip. So the stability of the hips, we're just going to feel, palpate the greater trochanter and the inner aspect and make sure that they are symmetrical. And then while we're still evaluating the hips, we can turn the baby over. We want to make sure we're supporting the head. And we're going to look at those gluteal folds, and they should be symmetric, and that's another indication of the hip dysplasia. We're also going to look at the back of the head at some of those sutures and fontanelles that we didn't get to see. And we're going to palpate the spine and make sure for each vertebrae. And there could be some stork bites on the back of the neck. This is normal. We could see tufting of hair at the sacral area, but this should be reported because this is an abnormal finding. There will be a dimple at the base of the spine, but this should be closed. And breast sound, we're going to listen to those breast sounds on the back that we didn't listen to in the beginning. So then some of the reflexes we need to check on the newborn is the rooting reflex, and this is going to be when you're stroking on the side of the baby's mouth. They're going to turn towards that stimulus and try to suck. And then the sucking reflex is if you stick a pacifier or your finger in their mouth, they're going to suck. And then there's also the the palmar grasp reflex and the plantar grasp reflex, which are pretty similar. But basically when you put your finger here, they're going to grab hold. And same here, it's going to curl and grab hold. And the tonic neck reflex, when you turn the baby's neck, they're going to bend this arm and extend this arm. And the opposite, when they turn this way, the arm will flex and the opposite will extend. The stepping reflex is when you're holding the baby up over a firm surface, and they're going to extend their one leg while the other flexes and then extend. So it's like taking a step. And then the truncheon curvation reflex when they're on their stomach. We're also going to see the Babinski reflex. We're going to test the Babinski reflex. And we're going to do this on their feet from the bottom, the sole of their feet. And we're going to go up in a J. We're going to go towards that big toe. And their toes are going to fan out like this. And the Moro reflex is when the baby is startled. So we can drop their bed, and we're gonna watch the symmetry of the arms and legs, and they're gonna flare out and like they're falling in C shapes. And we're gonna look at the overall muscle tone and symmetry of the baby. We're gonna feel the outlines of the bones and the shapes and all this, and also check the range of motion for each joint. We're gonna check the hips and the shoulders, and we're gonna check the hands, and we're gonna count all the digits, make sure there's 10 fingers and 10 toes, and that there's no webbing or no connectedness. We're gonna check the capillary refill in the fingers and toes, and we're gonna make sure that the nails hit the tips of the fingers. We're gonna make sure we're gonna check the creases in the palms, and we're gonna check the creases at the bottom of the feet. And after this assessment is over, we're just gonna make sure the baby is in a safe place. We're gonna cover the baby back up and make sure he's warm. We're gonna make sure that ID band is present and all the safety features are present, maybe tracking devices. We're gonna ensure ABC alone back and in the crib. And we're gonna make sure we cover baby back up and put them back with mom or the nursery. And that's all.